Hi, we're here with Brian Lancaster. He is CIO of Nebraska Medicine, which oversees a research arm and the hospital. Hi, Brian. Thanks for joining us.
Hi, thanks for having me.
So, I guess walk me through Nebraska Medicine and what's the hospital part versus what's the university part.
Yeah, so to be fair, Nebraska Medicine is the clinical enterprise. It's our health system. And then our academic partner who does research and education is the University of Nebraska Medical Center. So those are two different entities, but in essence, we operate as, for all intents and purposes, as one.
So you oversee the technology for both sides, right?
I do, yes.
So walk me through, the COVID-19 response, and how you had to move people remote from, I guess from two perspectives. One's the university side, the other one's the clinical side. And, I assume the moving parts are vastly different.
They are vastly different but related. So one of our complexities is one person could be a clinician, a teacher, a researcher. So they do all three of those different businesses, and they have different needs depending on what role they're in at that point in time. So as we approached kind of what I would call digital transformation, we've actually been on this journey for the last 4 or 5 years with working on automating our data center, making sure we're using private cloud techniques, allowing us to re-architect our remote access and deploy legacy systems via web portals and things like that. So we've been working on this for quite some time. And fortunately, I think we had done the preparation to allow us to quickly move to keep teaching, keep researching, keep caring while remote. So that's kind of the ounce of prevention is worth a pound of cure. We've been able, mainly due to work we did last summer, to kind of move everyone to a new remote access point that we branded as a digital campus, and then also as a work anywhere, anytime strategy. So that I think was very successful in allowing us to prepare for COVID-19.
So what technologies did you use to, sort of re-architect?
So from the data center perspective, so mainly the technologies we use were from the VMware stack. So kind of the virtualization in terms of our server infrastructure, and then our network infrastructure, NSX, vRealize Ops, vSphere, kind of those components. And then to the user, which was a big push this past summer, was Workspace ONE. So being able to take all that together and then expose it to the user. So if they're using a web client, a mobile client, or a legacy system, it all appears to them as kind of in that portal from a one-stop shop perspective.
And as far as what are the nuances for, clinical workers in the field? Because I know some hospitals, are moving certain types of workers remote, like whether it be social workers, and there's some moving parts there about what can go remote and what can't. What are some of the nuances when it comes to supporting that?
Yeah, so there's lots of considerations. So usually this gets quickly into the field of telehealth. So anything that was elective basically went to either be canceled or to a telehealth platform. So telehealth falls into two different types. One is referred to as asynchronous. So I could ask you a set of questions that goes into a queue, a provider picks it up and then responds. And that actually works pretty well with things like strep throat or to do an initial COVID-19 screen. So we've been using those asynchronous capabilities to do that, which basically was done through mobile app development and then also partnerships with our electronic medical record. Then I think what most people think about telehealth is real-time visits, so video visits. So basically what we did over the course of a couple weeks was shifted all of our scheduled ambulatory, so office visits, to be real-time video visits. And we basically did that through a Nebraska Medicine app, our digital front door, and then partnering with our electronic medical record, which is Epic, and then also Zoom technologies for the video visits.
Okay. How does HIPAA fit into this in terms of, I know some of that was relaxed with COVID and, a bunch of, things like that, but, how does the HIPAA, fit into the equation?
So I think both HIPAA and having a good security posture play into that, meaning just because HIPAA regulations are relaxed doesn't mean we want to, in essence, expose a new vulnerability to us from a cyber attack. And if you're not aware, cyber attacks are probably the highest they have been now for any industry, but certainly for healthcare. So we want to make sure we have a strong security posture, in addition to making sure we can address any HIPAA issues, even if those HIPAA issues have been released or relaxed, mainly because once we let telehealth out of the bottle per se, I think both our patients and our providers will want to do it because it's extremely convenient. So if we allow for a non-HIPAA compliant solution now, it'll be really hard to introduce security controls that we can control at some point in the future. So in essence, we're only allowing for the exceptions if it's truly an exception, like you attempted to use our HIPAA compliant approach and then it failed. We may allow for a one-off or something like that.
How do you work through the video conferencing stuff part of telehealth? Is it a case of shielding the connection, or is it more about the video conferencing, or is it more that it's integrated with some system that's HIPAA compliant? I guess how does that work with the telehealth?
Yeah, so the endpoints are all protected in kind of a HIPAA compliant deployment. So basically, we're using a system from our electronic medical record called MyChart that we've been basically embedded Zoom into. So MyChart has been HIPAA compliant and secure for decades, and now we can enable and turn on those video visits through it, if that makes sense.
Okay, so it kind of takes the video conferencing solution out of the equation, basically. Like it wouldn't matter if it were Zoom or BlueJeans or Microsoft Teams or whatever, it would be compliant because it's within the MyChart.
Yes, with a caveat. So
Okay.
There's only two solutions that I'm aware of that are compliant with MyChart, the Epic solution. That would be VidYO and Zoom. So that kind of obsoletes the ability to use Teams if we wanted to make sure it was HIPAA compliant in a future state. If that makes sense.
Yeah, so it's more about the integration with the basically electronic health record system.
Correct. And then we used a SDK from Epic MyChart to, in essence, create a Nebraska Medicine app. So the patients are working directly with it. When they click the video visit, it basically just seamlessly goes into Zoom versus having them to install Zoom and things to that effect.
What about the technology front for the people that are, truly on the front line supporting COVID patients? I guess what's changed since the outbreak, from a technology front?
So, and this is where I think we've done a lot of innovation, which I haven't seen other healthcare providers do. So when you're in the hospital, there's basically been a restriction of visitors because we don't want people who may be asymptomatic carrying the virus to come into the hospital and things of that effect. I mean, it's basically the quarantine order broadly, right? So what that has done is when you have a person a loved one in the ICU, it's really restricted ability for family members, and it's also requiring our physicians to use protective PPE, protective equipment to go into the rooms. So what we've done, and I haven't seen too many other people do this, is we're basically allowing the patient to get an iPad that has telehealth capabilities built into it. So the provider, the first respondent who's rounding on that patient can use telehealth and not physically go into the room. So that saves a mask or a glove or whatever that equipment might be. It also allows us to have loved ones kind of listen into the conversation It also allows loved ones to have interactions with their patients. And to put this into, I think that what's happening is we've had, unfortunately, a lot of patients ending, coming to end of life. And if we didn't have that technology, that telehealth component to allow for the loved one to come in and have that last moment, they wouldn't have had that last moment. So
Right.
both have been a way for healing for the family. It's also been a way that we've saved PPE because the physician and the care team can round on a patient without actually physically going into the room.
Was that in place before this, or was that something you improvised on the fly?
So this is probably the big story behind all of this. We've had a lot of this in place for a while. So we had a ability for a patient to get an iPad to manage their care, so they can see what they're scheduled for. They communicate with the care team, and basically the way that worked is we had a docking station that is controlled by a technology called ground control. Allows us to badge tap in, clean the device for a new patient, hand the patient the device, and they can manage their care. We had very little adoption of that technology. Both the care team and the patients weren't really too interested in it, which is interesting. Now we've seen a hockey stick up in terms of the adoption, meaning people are really embracing it and really appreciating it. And that's both on the telehealth capabilities on the inpatient side, as well as on the ambulatory side, the office visit side. We used to have to kind of entice physicians to want to do telehealth. Now it's basically went from 1 to 2% of our activities to 100% of our activities. So we're really seeing a widespread adoption. So our technology pieces have been rock solid. However, the change control pieces have still needed to be embraced. So it's a lot of training, adoption on the fly, a lot of user questions, and how do I do this? How to do that? What if this happens? And I think that's what we're working through right now is some of the softer points of the rollout, because we really didn't adopt it to the level we needed to prior to this event, if that makes sense.
So was that a project that would have looked like a flop pre-COVID, or it would have been like a long-term project without, a ton of runway, and then COVID happens, and now it looks like, you had a crystal ball almost.
Yeah, absolutely. And both from the remote work as well as the telehealth component, we were pushing for it from a leadership perspective and from an IT perspective, because we believe that digital is going to transform our business, but it was always a 1 to 2% so far. So it was, I want to work occasionally from home, or I might want to pick up 2 or 3 visits a day to do from a telehealth perspective. So we saw little adoption. So I think COVID-19 has really driven digital transformation in healthcare. We had to figure out how to do remote work. We had to figure out how to do telehealth. And I'm thankful that my leadership team had the foresight to invest in these technologies, and that investment I think is paying dividends right now. And I think post COVID-19, nothing goes back to normal. Meaning, I think our patients and providers who are now been experiencing the benefits of telehealth, they won't go back to the waiting room, waiting 30 minutes for their visit and those sorts of things. They're going to demand asynchronous and synchronous visits, and our providers will now want to do that too because they see the value in it. So I think it probably would have been seen as a flop or as a innovation, an R&D project. Now it's kind of table stakes.
Right. So what do you think, you mentioned the new normal. How do you see this playing out in terms of, the post-COVID landscape? Is it going to be, are we all going to rush back to work? Is there sort of some hybrid medium kind of state? I mean, I look at this too, right? I have a remote team. I had a remote team before. We're still obviously remote. So, nothing really changes per se, but, as we model out sort of everybody getting back to work, I do wonder how much sticks and how much, it won't be the way it was, but I'm just curious to get your thoughts on, how do you think it'll play out?
Well, I mean, I think there will be some slow return to work in a hybrid fashion just because of the managing the virus. I think that's going to play out for the next several months, unfortunately. But if you take that off the table, in my opinion, and this is one of the reasons I was so so gung ho, so pushing for this type of technology, is if you just look at the space we have at Nebraska Medicine, at the University of Nebraska Medical Center, we're running out of space. So it's very costly space, and I'm in Omaha, so I'll gripe about my 45-minute drive, but it's still 45 minutes, hour and a half a day, which would be fantastic in other aspects of the country. But why waste that time if I can be productive at home? And so I think we were pushing for it to save on space, to have a sustainability impact, and then also to be more productive. And so I think now that people have been forced into it, they'll see the value in doing it. And I think you'll see, likely a more of a hybrid rise in all roles doing remote work, not just technology-based roles. And I think that'll also get to a change to what our physical space at work looks like. And you see this with more in the startups and the technology firms. But I would push for this back at Nebraska Medicine. How do we create maybe not named offices, but shared space for workers that you can, when you need to have an in-person meeting or a collaboration for whatever reason, you can go reserve it or go pick it up and just use it, but you don't have dedicated space, which I think would save us a lot of capital money. And I think it will also allow us to be more productive.
Yeah, I mean, I've been seeing the CFO surveys, and that's pretty much where things seem to be going, right? It kind of looks like a win-win for the worker and the company. So yeah, is there anything I didn't ask that I should have?
I think you covered most of it. I do think a lot of this gets into kind of a cloud strategy to some extent. So one of the reasons it took us 4 to 5 years to get to this point was all the kind of the cloud work we had been doing. And for us, cloud work is mainly private cloud with then adoption of SaaS systems, and then to expose those to an end user in a way that looks seamless. And that's really what we did in the last little bit here, the last mile, if you will, through our remote access work. But I think that all ties onto a cloud strategy, if that wasn't clear from the earlier remarks.
All right. Well, thanks for joining us.
Thanks for having me.